Welcome, colleagues. On behalf of SelfMade Health Network and our parent organization, Patient Advocate Foundation, we would like to welcome you as well as members of your team and partners to today's webinar as part of the Opening Doors webinar series. I'm Dear Dewana Calhoun, Director of the SelfMade Health Network, and we will be joined shortly by today's keynote speaker, Dr. Caroline Chen, Program Manager of the Asian Smokers Quitline. We're delighted to host this webcast in collaboration with our partners at APPEAL, our Asian Pacific Partners for Empowerment, Advocacy, and Leadership. We're also a member of the CDC's National Network. We hope that you find today's information presented as well as the complementary resources provided on today's topic, Embracing Asian Americans with Tobacco Cessation Support, beneficial to your organization, your partners, your clients and patients, as well as your community. Before we begin, we will share a few tips and housekeeping reminders. As we begin today's webinar, we are glad to share with you that this webinar is recorded and will be made available for future viewing within the next few days. You are welcome to provide this important update to your colleagues or partners. If you are in need of additional technical support, please visit the help icon at the bottom for a list of the most commonly asked answers to the most commonly asked technical problems. And very important for today's webinar, since everyone's monitors and display settings are different, the good news is that you can expand your slide area if needed by clicking on the maximize icon on the top right of the slide area, and by dragging the bottom right corner of the slide area. So we understand your excitement about today's topic and would ask that questions be submitted during the Q&A session. And for social media lovers, you are welcome to tweet using the hashtag #OpeningDoors at SelfMade Health at any time. And lastly, because your feedback is important to us, we're asking all participants to please complete the brief post-webinar survey at the end of today's webinar. Your responses are used to better assist us with identifying and addressing your future and current needs as well as interests. Today's webinar includes a few poll questions, so please feel free to participate even if you're unsure about the answers. All responses are confidential. And we will begin by providing a brief overview about our SelfMade Health Network, and then we'll transition to our keynote speaker, Dr. Chen. The SelfMade Health Network is one of the most recent members of the consortium of 8 national networks that are funded by the Centers of Disease Control in the Office of Smoking and Health in partnership with the Division of Cancer Prevention and Control to advance prevention and control efforts involving cancer-related as well as tobacco-related disparities. Our priority populations include populations with lower socioeconomic status characteristics that reside in both rural and urban communities, as well as frontier regions throughout the United States. Our self-made health philosophy originates from the self-made concept and understanding that in the presence of affordable, supportive, and resource-friendly environments, not only will individuals and families accrue greater awareness and knowledge, but populations will also accrue greater efficacy as it relates to the decisions that they make about their health. And in the presence of sustained local and regional infrastructures coupled with evidence-based resources, decisions that are made among vulnerable populations will be consistently applied throughout the entire continuum of health. Although this concept has been modernized, it is based on a historical perspective and belief that a man, a woman, and a teen can indeed become the captain of his or her own destiny. Based on the understanding that the improvement of health outcomes is indeed a process, we at SelfMade Health Network strive to continuously evolve and move forward over the next few years and decades. We envision a nation in which vulnerable populations residing throughout various regions in the United States have equitable not only access but awareness about geographic and culturally relevant information and resources. And as valued members of society, these populations would routinely utilize these services, leading to greater opportunities for more informed decisions about cancer protection, as well as living cancer-free and tobacco-free lives. A few examples of some of our priority populations are noted on the next slide, and they include smokers with lower socioeconomic status characteristics, which also includes smokers with limited or lower levels of education, smokers with medical comorbidity, as well as older smokers. There's reference in the United States Public Health Services Clinical Practice Guidelines for treating tobacco use and dependence. Several factors can affect the acceptability, use, and effectiveness of tobacco dependence treatment. So this information is especially important because most of the special populations noted above bear a disproportionate burden from tobacco use or possess higher smoking prevalence. And in some instances, these categories of characteristics may overlap. We hope that by the end of today's presentation, you would have learned a little bit more about special populations that possess one or more of these characteristics. And more specifically, based on today's presentation, we'll learn a little bit more about Asian American smokers. So according to the CDC's most recent data, nearly 17 out of 100 United States adults aged 18 and older currently smoke cigarettes. So this means that an estimated 40 million adults in the United States currently smoke cigarettes. Smoking rates tend to vary among populations as well. So in comparison to the national smoking prevalence of 16.8%, smoking prevalence among some Asian Americans, as noted above, range from 8.8% to 26.6%. Now, according to the CDC reports, the three leading causes of death among Asian Americans and Pacific Islanders are cancer, heart disease, and stroke, all of which can be caused by cigarette smoking. Asian Americans represent a wide variety of languages, dialects, and cultures. And by the end of today's presentation, we hope to learn more about contributing factors associated with smoking prevalence. Most current CDC data also reveals that among special populations, including those that possess lower levels of formal education, smoking rates in particular remain highest among adults whose highest level of educational attainment include a GED certificate, as well as those who may not necessarily possess a high school diploma. It may be helpful to also examine smoking rates and tobacco use rates among your respective patient and client population, as well as at the state and county level. And if you're interested in more macro level data, city, census tract, and zip code level data may also be helpful or beneficial to your healthcare setting, or to your public health setting, or to your service setting. As shown above, the next slide is just a brief logarithm of the 5 A's models related to assisting tobacco users with quitting tobacco. They include ask, advise, assess, assist, and arrange for follow-up, based on the United States Public Health Services Clinical Practice Guidelines for treating tobacco use and dependence. But before attempting to implement some of these evidence-based strategies or interventions, it may be equally helpful to consider additional contextual factors that may impact when, what, why, and how decisions are made by special populations throughout these processes. So we look forward to obtaining greater insight from Dr. Chen's presentation related to these factors that impact Asian Americans as special populations. In addition, cultural barriers, lower levels of health literacy, and limited English proficiency have been coined the triple threat to effective communication by the Joint Commission. These threats pose a challenge related to an effective provision of care at various levels, including the system, provider, and patient levels, and in some instances, timeliness associated with accessing available evidence-based information, services, and resources. The causes of health-related disparities are multifactorial, encompassing access to care, the disease-related factors, neighborhood or residential factors, as well as provider and patient factors, which also include cultural and linguistic barriers to health literacy. So as noted above, is just a basic depiction from the Institute of Medicine's report, Health Literacy, A Prescription to End Confusion. And it features just a number of potential intervention points associated with health literacy that impact health outcomes and costs. And so more specifically, the low health literacy is one of the important risk factors related to cancer health disparities, and it can potentially impact decisions made that are associated with seeking health services and healthcare outcomes. Considering these factors is important as we seek to increase the number of adults, including special populations, not only seeking but utilizing health-related services much earlier. So this would also include tobacco cessation or quitline counseling services and other evidence-based forms of cessation support implemented by members of the healthcare and public health teams employed in a wide range of environments. Health literacy can be integral to not only the 2020 Healthy People national goals, but essential services of public health framework that's depicted above. Health literacy is one of the many important factors affecting not only the quality of consumer or patient-provider engagement, but also impacts decisions made by both the patient or client as well as the healthcare or service provider, thereby potentially impacting at least two categories featured within this framework: inform, educate, and empower, as well as the timeliness associated with linking clients to care and services. In addition, the good news is that evidence-based tobacco cessation and telephone quitline service counseling services have a broad national reach to support all of the special populations featured earlier with quitting tobacco, and they also assist in minimizing cost and transportation barriers associated with linking special populations to effective cessation counseling support. More specifically, in the telephonic medicine. As noted by the United States Public Health Service's clinical practice guidelines for treating tobacco use and dependence as well, social support is an effective mechanism that should be integrated as part of treatment when providing assistance to tobacco users. So we hope that by the end of today's presentation, you would have learned a little bit more about why your role is plays an important part in this social support process and how to tailor approaches to reach and assist even more special populations with quitting tobacco products. Without further ado, please join us in welcoming today's featured speaker, Dr. Caroline Chin, who is the project manager of the Asian Smokers Quitline and a postdoctoral researcher at the University of California, San Diego. Her research focuses on Asian and Asian American populations, public health, behavioral health, and smoking. She holds an MLA from Harvard University and an interdisciplinary MPH and PhD with an area of concentration in aging, as well as Asian health and social and cultural factors. Dr. Caroline, welcome.
Thank you, Dwana, for the warm introduction. Hi, everybody. Thanks for joining us today. I'm very eager to tell you about the Asian Smokers Quitline and what it can offer the Chinese, Korean, and Vietnamese-speaking smokers in your state, communities, and clinics. First, I'd like to acknowledge the Centers for Disease Control and Prevention for supporting ASQ, and also to Dwana Calhoun of the SelfMade Health Network for making this webinar possible. I'd also like to thank Joanne Lee at Appeal for promoting this webinar to her network, and also to thank all our collaborators here at UC San Diego, as well as the various state and tobacco control programs and community partners that have worked with us over the years to make these Asian language services a nationwide reality today. Today, I will introduce ASQ, talk about who we help, talk about the Asian American cultural norms and its relationship to smoking, and lastly, how triaging to ASQ can help make the world a better place. The mission of the Asian Smokers Quitline is to provide accessible, evidence-based cessation services in Cantonese, Mandarin, Korean, and Vietnamese to Asian communities in the U.S. by providing support in the form of one-on-one individualized counseling to smokers, informational materials in Chinese, Korean, and Vietnamese language, and as well as 2 weeks of free nicotine patches that are mailed to the smokers' homes. ASQ is open Monday through Friday, 10 a.m. to midnight Eastern Time, or 7 a.m. to 9 p.m. Pacific Time. So when smokers make initial contact with the Asian Smokers Quitline, they will be enrolled, which is a process that takes about 5 to 7 minutes. Counselors will assess the caller's needs and ask if they have time for their first counseling call right then. If the caller is a smoker, the caller will receive materials such as a decision guide on the quitting process, as well as other information on controlling cravings and the benefits of using nicotine replacement therapy. If the caller is a proxy, that is, someone who is calling to help somebody else quit smoking, they will receive information on how to support the smoker, and then the counselors will try to get the smoker to call ASQ and quit smoking. So if the caller is a smoker and they're ready for the first counseling call, also called the info call, the counselor will help the smoker develop a quitting plan and set a quit date. ASQ provides up to 4 further proactive follow-up calls to support the smoker, with calls scheduled in the first few days after the quit date, as this is the time when relapse is most likely. And as I had mentioned before, ASQ also provides 2 weeks of nicotine patches after enrollment, given that the smokers are over 18 years of age and an everyday smoker. So as we know, English cessation help is available throughout the U.S. through the 1-800-QUIT-NOW portal. Until recently, Asian language smokers who have trouble understanding English could access these services through a third-party interpreter. Asian language cessation services were first offered in California in 1993. Dr. Shuhong Zhu, the principal investigator for both the California Smokers Helpline and what was later to become the Asian Smokers Quitline, paved the way for all other state quitlines with this randomized control trial that established the evidence base for quitlines as a population-based intervention against smoking. Between 2000 and 2010, Asians became the fastest growing immigrant group in the U.S., increasing by 43% and growing from 10.2 million in 2000 to 14.7 million in 2010. The question was raised, could California state's Asian cessation lines provide services for Asian American smokers who lived in other states? With the support of a CDC dissemination and implementation grant, the feasibility of expanding services was tested in 2010 with 5 other states. The initial states were with Colorado and Hawaii, and then eventually New York, Washington, and Texas joined this multi-state pilot. The multi-state study showed that expanding the services was indeed feasible. This led to the expansion of Asian language services to the rest of the states in the U.S. in 2012. Now, any Chinese, Korean, and Vietnamese-speaking smoker can call ASQ and receive services free of charge. Any state quitline can also triage Chinese, Korean, and Vietnamese-speaking residents to ASQ, and this too is free of charge. So this section is about who is smoking in the Asian American community. We help Asian Americans who have language barriers quit smoking. According to the 2013 American Community Survey, there's an estimated 5 million Chinese, Korean, and Vietnamese Americans who have trouble understanding English living in the U.S. 70 to 80% of them are foreign-born, and as this slide shows, 78% of them speak Asian languages at home. According to the 2010 census, only half of the foreign-born Chinese, Korean, and Vietnamese Americans report speaking English proficiently. These data show smoking prevalence of Asian race as an umbrella group, with men and women together, by language ability. Asian Americans who are proficient in English have a much lower rate of smoking prevalence than those who have limited English proficiency. These data are from the California Health Interview Survey. It's one of the few statewide surveys that ask survey questions in multiple languages. So we see here that Asian language speakers who have not yet achieved English proficiency, perhaps they are new Americans or they live in an ethnic enclave with little opportunity to learn English, tend to smoke more. Gender differences are also visible in affecting smoking, associated with different smoking prevalences. So these data are collected from also in language translated surveys. Among the Asian American population with limited English proficiency, we see that men smoke more than women by quite a bit. Chinese American men who chose to fill out the California Health Interview Survey in Chinese have smoking rates that were nearly 20% as compared to less than 1% for women. And studies on limited English proficiency Koreans in one country in California revealed a smoking prevalence of 39% for men and 6% for women. Surveys in Vietnamese men in California revealed prevalence rates between 25 and 31% for men and less than 1% for women. So when you look at limited English proficiency and male gender together, you find a disparities group. These disparities can be explained in part to carryover from different smoking norms from the country of origin. 2009 data from the World Health Organization showed that approximately half the men in China, Korea, and Vietnam smoked less than 2%, or approximately half of the men in China, Korea, and Vietnam smoked, while less than 2% of Chinese and Vietnamese women smoked. The prevalence rate of Korean women was slightly higher at 7%. While individuals who leave a country to move to another country are inherently different than those who stay, familiarity with the norms from the country of origin may help explain and may help us understand why some new Americans may have different smoking habits than their new neighbors. So this is time now for our interactive poll. There are two in this presentation. Please click on what you believe is the right answer to the question directly on the screen. Okay, did everyone choose an answer? Great. So it looks like the majority have answered false, and in the next slide we will see that this is indeed true. So this slide shows where the largest Chinese, Korean, and Vietnamese populations are in the U.S. And as you see, there's quite a wide spread. For example, in Texas, Asians make up 7% of the population and has increased by 72% from 2000 to 2010. High concentrations of Asian Americans live around Dallas and Houston. About a third of California's population is Asian American. That's 5 million. This number actually does include Indians and Filipino. It's kind of an umbrella Asian alone category, I must say. Washington has also seen a 50% increase in Asian Americans, while Pennsylvania has seen a 62% increase between 2000 and 2010. So if you take Texas, California, Washington, and Pennsylvania together, these have the largest populations of all three Asian language groups that ASQ serves. New York, New Jersey, Illinois, and Maryland all have high concentrations of Chinese and Koreans. So from the 2010 census, we learned that New Jersey has seen a 50% increase in Asian Americans since 2000. Florida and Massachusetts both have high populations of Chinese and Vietnamese. And Georgia and Virginia have high populations of Koreans and Vietnamese. Georgia has seen an 83% increase of Asian Americans from 2000 to 2010. Lastly, it's interesting to point out that North Carolina and Louisiana are home to a great number of the Vietnamese in the United States. So here's a thematic map of Asian American populations in the U.S. with the number of ASQ enrollees overlaid to the map since August 2012, when the Asian Cessation services became national. So as you could see, there are a lot of blue places on the map. Asian Americans are everywhere in the U.S., and ASQ has enrolled nearly 10,000 smokers from 49 states and Washington, D.C. as of March 6th, or 3rd. So here's some information about our callers. Among the three language lines, enrollment in the Korean line is slightly higher than on the Chinese and Vietnamese lines, but the difference is not too great. They're pretty evenly split. So proxies, the idea of proxies. Proxies are people who call and enroll in ASQ cessation services to ask for help for somebody else who smokes. From our experience, proxies have been the wives of smokers who want their husbands to quit. So we have about 5% proxies calling ASQ asking for help. Okay, so for the following slides, we're just going to look at smokers only. Smokers that have called ASQ for help only. Most smokers that call us for help are male, but there are also a group of female smokers that call for help as well. We're often asked whether we receive many calls from pregnant smokers. Out of the 392 female smokers that have called since 2012, only 3 were pregnant, so the number is actually quite low. Overall, older smokers are calling for help quitting. We get the largest number of callers from the 45 to 65 years of age category. Most smokers who call for help have more than a high school education. And over 40% of ASQ's callers are uninsured. Callers have mentioned to us that the free patch giveaway provided them an extra push, an extra incentive for them to make the initial call for counseling. Most of ASQ callers heard about the cessation services through ethnic media, radio, newspaper, TV, online. All of ASQ's promotions are, of course, in language because our target audience are Asian language speakers that have limited English proficiency. Later on in this presentation, I will show you how you can access some of these promotional materials, both from us and also from CDC's MCRC, Media Resources Center. So I'm going to talk a little bit about Asian American cultural norms. So linguistically appropriate services, they're just half the story. Services that are culturally tailored are just as important too. Values that are important to Asian families include thinking about the needs of the group, considering the family and respecting elders, maintaining harmony in relationships. On the subject of smoking, these cultural norms may create unexpected challenges. For example, from the 2010 census, we learned that 28% of multi-generational homes in the U.S. are headed by Asian Americans. So this means that it's not uncommon for several generations to live in the same home. Grandparents may be living together with their children and their grandchildren, and when new relatives arrive in the U.S., they may also be a temporary guest in the home. That could be for a short time, or that could actually be for an extended period of time. The traditional structure of the family may make it harder for non-smokers to have influence over the smoking behavior of other members of the family. Well, the smoker may be older, so to tell an elder to stop smoking may be difficult for the non-smoker in the family. Or the smoker may be a male relative, or the smoker may be a guest. So not wanting to be rude when faced with unwanted smoking behavior, non-smokers may choose not to confront the smoker. Non-smokers may instead, 1, try to avoid the smoker, 2, just tolerate the smoke, 3, tell their children to avoid the smoker. Counselors at ASQ can help here. They can help reframe the problem. Some of the smoking themes they discuss with Asian American proxies and smokers include how quitting smoking could be a way for them to set a good example for their children, that by adopting a healthier lifestyle, they can extend their longevity and see their children grow up. Counselors can also educate callers about protecting the family from secondhand smoke, and also help them clear up myths that may be perpetuated from smoker to smoker, such as breathing in smoke can help their lungs become stronger, or it could rebalance the qi. These are some stories that counselors have shared with me, that smokers have these health beliefs that are not exactly, or they're just wrong. Throughout the counseling process, ASQ counselors assess the family context in order to determine whether other family members may be enlisted to help the smoker quit. So if you frame that into how the group can become stronger and the future brighter for future generations, that could help. Since cessation counseling is often not familiar to callers, ASQ counselors work very hard to engage the callers as soon as they call in. Callers often have already tried to quit on their own and relapse before seeking help. At this point, they sometimes feel they've failed and feel shame, and the counselors help reframe quitting as a process. Dr. Gary Tedeschi is ASQ's clinical director, and he'll be presenting a webinar later this summer to talk more about ASQ's counseling. So, triaging to ASQ. Here's some ideas about how you can partner with ASQ to help the Chinese, Korean, Vietnamese language smokers in your state, community, and clinic. You can direct smokers to learn more about the services that are available to them on our YouTube channel. These are 3 of our counselors. They're answering some of the most frequently asked questions about our services in Korean and in Chinese, in the Asian languages. If you don't speak an Asian language, you could still understand the responses because we put in subtitles. You could post a link of our counselors' YouTube videos to your website, or ask your patients to watch the videos to learn more about free materials that we provide and the counseling process. Or another way to be involved is if you're a provider, now that you know how the family is a very, very durable and strong unit in Asian American culture, you can try to identify who in the family may be a champion for the smoker quitting, and who can you empower. Can ASQ play a role in offering support? Proxies can be referred for help too. So remember to look beyond the individual to see who may be getting hurt from secondhand smoke and who may help the smoker quit, and how the smoker can help themselves. Okay, pop-up quiz 2. Can healthcare providers refer patients and clients to Asian Smokers Quitline? Just take a moment. choose what you believe is the correct answer directly on the screen, and then we'll take a look. Yay! That's true. Basically, anybody can refer smokers to ASQ. Quitlines can refer smokers to ASQ. Actually, the Arizona Quitline has found that web referral is quite simple to use. Let's see, providers and nurses and pharmacists can sign up and refer their patients and customers to ASQ. We've heard some resistance from some pharmacists who pointed out, well, you're giving out free nicotine patches, and we sell them. But we remind them, well, once those 2 weeks run out, then the smokers might come back and get some from you. Faith-based groups have been very supportive and referring people to ASQ, as well as community-based groups. And I'd like to give a shout out to Ken Ho from AFI in New York City, who's referred the most number of smokers to ASQ over any group that we've partnered with, including healthcare plans. Employers can refer their employees to ASQ services, as well as international student offices. We've been getting calls from university offices asking for help because their campus has gone smoke-free, and some of the international students are smoking in the dorms or smoking outside the dorms. And so I should probably have added to the list also public housing administrators can refer people to ASQ. If you're a researcher and you're interested in testing Asian American health promotions, you can contact me directly and we could speak more. And ASQ is also expanding, or is also exploring the possibility of becoming we also have this capacity to set up e-referrals, and we have currently that relationship with the UC medical schools. And we're exploring now the possibility of becoming a specialized registry, so we could qualify health providers and plans that refer to us for meaningful use credits. Email me if you're interested in any of these topics. So to web refer, it's really simple. Just go to the ASQ website. On the menu bar, there's web referral. Hover over it. Register your organization appears. Click on register your organization. I'll approve it. And then you don't have to register anymore. The next time you want to refer a patient, just click on web referral and refer the person, and we'll call them back. You can also promote ASQ by asking us for free materials. We have wallet cards, postcards, rack cards, posters, and flyers that describe our services. So, when patients are waiting in the waiting room, they could see a poster, decide to change their lives. And we also started to co-brand our materials with different provider groups. So you can contact me about that. So just triage to us. We'll get to work. And you can also get free promotional materials from the CDC's Media Campaign Resource Center. And they store the Chinese, Korean, and Vietnamese promotional materials that have been created by a partnership who handles all of ASQ's marketing. If you wish to lead a media campaign in your state or community, you can get materials here. Colorado, Maryland, Hawaii, and Washington have all promoted ASQ in this way. Community groups like APCAT in Seattle have also promoted ASQ as well. So it's really easy to get materials from MCRC. You just browse for the detailed search, type in ASQ, and choose what items you're interested in. And then you can register, and you have to sign an agreement for releasing the materials. And then you get a link to download materials. So lastly, if you are a state, consider having your Quitline automatically transfer or triage Chinese, Korean, Vietnamese speakers to ASQ. You'll save on translator fees and provide a more comfortable and likely effective counseling experience for your residents. what you need is a state quitline transfer number. Just email me and I'll share those with you. Roswell Park, National Jewish Health, Arizona Quitline, and Clearway, Minnesota have already adopted these new ASQ quitline numbers. If you're with a Lear, you might actually, if you have the pop-up window option, you might already have the option to triage to ASQ directly, but you might want to check. And if your quitline number is 1-800-QUIT-NOW, then you can use one of the 3 take-back and transfer codes that NCI kindly created for ASQ's lines. So after *6, instead of transferring to a different state, you just transfer to ASQ's Korean or Chinese, Korean, and Vietnamese lines. So the codes are 80, 81, or 82, respectively. You can also add questions to your state or clinic's intake. Perhaps consider adding a question: what language do you prefer to speak, or what is your primary language, to the list? Remember that among Asian Americans, limited English proficiency plus male gender is associated with higher smoking prevalences and is a smoking disparity group. For this and other long-term advocacy strategies to support Asian families, including tobacco, consider coordinating with Joanne from Appeal to learn more. In closing, if you bridge the Chinese, Korean, and Vietnamese populations in your state to our linguistically and culturally appropriate services, this is great. And if you're a state that receives quitline capacity funding from the CDC, let them know on the quitline work plan template. On the cessation worksheet, you'll find 2 new questions related to ASQ use. Let them know, and please let us know at ASQ. We're looking forward to learning how to partner well with stakeholders, and we love feedback. I mean, that's how we make progress. So, ASQ is here to fill a gap. We're here to help. Triage your Chinese, Korean, and Vietnamese-speaking smokers to us, and our counselors will provide them the linguistically and culturally appropriate support to help them quit. If you'd like to receive studies that document ASQ's evidence base, or if you have any questions about anything that I've mentioned in this presentation, please feel free to reach out. I'm very fast on email. Thank you for taking the time.
Hello, everybody. This is Kelly. I am the facilitator on this session. It looks like it is time for taking questions from the audience, and I can see that a number of them have come in. Caroline, a lot of folks are asking about whether or not you have any information specifically on the Burmese populations in the United States, any statistics as well as educational information and materials.
Hi, we've been asked about Burmese as well from the CDC. I've done some searching. We currently do not, but we have been having internal discussions about, maybe we could try to partner with different groups that are working with the Burmese population, and then we're better able to assist by referring. But at the current time, we unfortunately do not have information materials in Burmese, and we don't have anybody who speaks Burmese on staff.
Another question that came in asked whether or not you provide support to other members of the Asian communities through your Quitline as well.
A number of questions have come to us over the past couple years about support in Hmong, support in Cambodian, recently Laotian, actually last night, Laotian. Unfortunately, we currently do not, but we really want to help. So we're kind of reaching out into the community, and if anybody is on this conference call, or on this webinar who does serve any of those communities, please let me know, because perhaps we could, perhaps we could link people, link communities to resources, even if we ourselves do not provide those resources directly.
And one more question of whether or not you know of any other assistance programs, either locally or at the state base, that do assist folks of other languages, even if you guys cannot.
It sounds like we really should start kind of a sort of database so that we would be able to link people. Right now, we do not. We have a lot. We have a list of our partners, and we're trying to expand the list. As I mentioned in the presentation, most people hear about us from paid media, so that's very direct. Someone sees an ad and then they call us. But to have like partnerships with community-based organizations, with other groups out there that are doing really good work, that's something that we would like to build, but we're not quite there yet.
Okay, thank you. And then there was a question that came in about some of the flyers within the platform that weren't loading, and I was able to correct that, and I was just going to let everyone know, all the audience members, that if they refresh their browser, they should be able to access any of the flyers that were previously giving you difficulty. If you still are having trouble, email us following the session, and we will send them directly to you. And then one last question just came in about whether or not this PowerPoint presentation would be made available to the attendees following the session. And yes, it will be. It's also in the very top of your supplemental materials list inside the console. But again, if you're having trouble connecting to it or downloading it, just let us know and we'll send you a direct copy following the session.
Oh, great. Thanks, Kelly. Thanks, Dr. Chen, for providing us with such a wonderful presentation and a lot of information as well. That includes a lot of information. And in addition to the resources that Dr. Chen has mentioned, displayed above is just another example of one of the brand new resources that is featured in the CDC's most recent Tips for Former Smokers campaign. That's available to all organizations. And the good news about this particular ad is that it is based on a cancer survivor, Rico's experience, and he was a former tobacco user. And on the next slide, we just wanted to kind of remind everyone to please complete the post-webinar survey, as well as just once again thank Appeal and our partners at Appeal as well. And on your slide that's featured, thank you. Thanks, Kelly. Appeal, we want to thank you for all the support that you provided. And then the next three slides will kind of depict a couple of resources that focus on cancer survivorship. Just as a reminder to some populations who use tobacco and may already be diagnosed with a cancer, a tobacco-related cancer, there are resources available. And so the good news is that these resources are available throughout the United States and can be shared with various types of organizations as well to assist your patients with additional support once they're diagnosed with cancer. And when you visit the CDC's website, if you navigate to the related links section, you'll see a list of more than 100 organizations nationwide that not only provide emotional and practical support, but financial support services for adults that are diagnosed with cancer, but they also provide information about services that are available to caregivers or families that are impacted as well. So it's more than helpful to share that information with your neighbors too. And then lastly, these ads can be featured on Twitter or on your website as well. And if you're looking for ideas, we also have a few of the ads featured on our Twitter handle as well. And once again, we want to provide you with just a snapshot of our website. As Dr. Chen mentioned, we'll also continue with another series of webcasts, and so please feel free to visit our website as well for updates regarding upcoming webcasts. And our next webcast is scheduled on April the 21st, so please stay tuned for additional information. And as always, we want to thank you again for taking time to learn more about how we can address health disparities across the nation. And we hope that everyone has a good day. If there are no other questions, I don't see any more questions in the team chat. Box, do you, Kelly? Okay.
No, I think that's it.
Okay, thank you. Thanks, Dr. Chen, once again, and thanks, everyone. And please feel free to share these resources with your colleagues and partners as well. Have a good day. Goodbye.